Hi, I'm Sandra Barrington, Executive Director of Sierra Nevada Memorial Hospital Foundation, and welcome to Doc Talks. This is a series where we bring local physicians to you to learn a little bit more about their background, how they got to where they are in their career. We'll talk a little bit about what happens in our community, and then what the future of healthcare looks like for them in Western Nevada County. And today we are welcoming back Dr. Clayton Hess. You can go to our website to see the very first Doc Talk that we did with Dr. Hess, but we brought Dr. Hess back to talk a little bit more about cancer and cancer survivorship. He is our local radiation oncologist. Welcome.
Thanks for having me.
Well, thank you so much for being here and coming back on Doc Talk. This is the first time we've had a doctor back to go more in depth, so very exciting episode.
It's a privilege. Yeah.
And we wanted to talk a little bit more about cancer survivorship. We talk a lot about what happens in treatment, but what does a cancer survivor do after they've gone through treatment, they've graduated, as sometimes we call it, and what does life look like post-cancer treatment?
That's a great question. It's been the focus of my attention for quite some time now, a number of years, optimizing that. Mm-hmm. So there's quite a bit of a safety net throughout treatment, weekly visits, monthly visits, sometimes even daily visits, to help navigate a patient diagnosed with cancer throughout their diagnosis, staging, treatment planning, and essentially either chemotherapy, surgery, or radiation, now increasingly immunotherapy as well. There are some patients who receive maintenance treatment, and that's basically you're done with almost all your treatment, but you're going to need this pill, right, for a number of years. So remission tends to start when active treatment ends, and that's, that milestone, celebratory milestone of when you're done with treatment. You get a diploma sometimes, you ring a bell sometimes, yes. But it is the celebratory moment when a patient with cancer reaches this rest period, where the treatment is done and the hopes are that the cancer has been entirely annihilated, destroyed, cut out, poisoned, whatever you want to call it. And if that is true, then the patient is cured. The problem is, how do you know it? Mm-hmm. So remission is the word that we use because we're too chicken to use cure. Mm-hmm. Mm-hmm. So many patients will have, 99% of their cancers killed, which means there's some small number of surviving cells. Either they were missed by the surgeon or the radiation almost killed them, but not all of them, or they had spread to another location. And we never know it. The only way to know it is the passage of time. Mm-hmm. So remission is that period when you're hopeful for cure, but too uncertain to say it for sure. Mm-hmm. So it then requires this ongoing visit, ongoing surveillance, and that is survivorship, plus management and optimization of all of the toxicities, the cost of the treatment. So optimal survivorship is a life where there's few side effects from the treatment and ongoing assurance that the cancer colony has not regrown.
Okay. And what would you recommend for people as far as regular checkups or things that they can do post-cancer, maybe even holistically, that would help them in their survivorship days?
Yeah, it's a great question. It's got a complicated answer. Mm-hmm. So in two phases. Globally, the answer is, that's a controversial question. Mm-hmm. There are federal guidelines for the remission piece where you're doing surveillance. How often should I get a scan? How often should I get an exam? There are federal guidelines that the NCCN, which is the National Comprehensive Cancer Network, publishes, and it gives a range. So just as an example for listeners, if you have early stage breast cancer, most of the time the recommendation is to have a mammogram it's a mammogram once a year, and it is a breast exam anywhere from 1 to 4 times a year.
Oh, okay.
So that kind of shows you...
It's a big range.
It's extremely broad, right? Like, well, come once a year, come once a quarter, right? It's very discrepant. And the reason for it is there's not a lot of evidence to say that one way is better than another. Mm-hmm. So often it's about peace of mind, proximity to the doctor's office, desire to have additional care versus aversion to those things. So even just within the category of, is my cancer gone entirely, there's controversy about how often or how infrequent to do that. Mm-hmm. That's all based on historical paradigms about kind of based on the following premise. Well, if they're not cured, there's probably no way to cure them, so it might not matter because the cat would be out of the bag anyway and we couldn't cure it entirely. That has been kind of the overarching theme that has informed a lot of the federal guidelines for decades. I personally, and I think a lot of people, are really starting to challenge that paradigm. So for the portion of survivorship that is about remission and keeping a good watch on the cancer, the counter argument to that is the earlier you catch it, the more options you have.
Yes.
However, the more resources are required to do that. So it ends up being this careful striking of a balance where you and your provider or the survivorship team or whichever provider or multiple providers is participating in your care after treatment. How often should you see each, and how often should you order the scans? It's going to be a discussion based on what you want and the probability of it regrowing. What I envision is tailoring that so that those who are at greatest risk get the most active surveillance, and those at lowest risk have a reprieve from that. There are no federal guidelines that tailor your surveillance plan to your risk. So if somebody is very high risk for having it regrow, it makes logical sense that you should do lots of scans and lots of exams. That's not captured in national guidelines, and it's a shame. So that's kind of where we're at the forefront of survivorship, daring to do things differently because it's probably the way we'll do it in the future.
And it sounds like it needs to be customized per patient and wants and needs and their specific case.
So that's what we call a survivorship plan, where you would take that into consideration. These are fostered and recommended by certain professional groups or certain groups that give credentialing. Some of them will require that cancer centers have these survivorship plans. And it would basically take a particular patient, inquire what treatment they received, where they received it, what dose, and like what chemotherapies, what immunotherapies. And that would basically allow them to then predict what side effects they would have and how at risk they are. And you would tailor it. So for you, we're going to do it once a quarter. And I'm really worried about this area, so come back to me in 2 months, versus someone whose risk is 1% or 2%, come back in a year.
Okay.
So.
Yeah. So what would you see as the future of cancer care in our community?
So I don't see a reason why that can't become a reality. So, at Sierra Nevada, we're striving to tailor that survivorship and make it so that any particular person has their survivorship plan, not just a generic one.
That's great. And that goes with the philosophy of our cancer center of treating the whole patient, not just the disease, and looking at each patient as an individual and holistically.
Agreed.
Well, thank you for joining us today and giving us a little bit more deeper dive into survivorship. And this is Doc Talk. You can find us on supportsierranevada.org or on Nevada County Media. Thank you for joining us.